Hey everyone, welcome to the Brown Bag. Sarah, I wanted to ask you quickly, can you hear me?
Yes, I can.
Okay, great, thanks. All right, welcome everyone. We're glad to have you for today's Brown Bag in Science webinar. The goal of this webinar series is to familiarize our ACSM students and young professionals with the breadth of science that ACSM members conduct. This month, we are very excited to welcome Dr. Sarah Kamhai as our presenter. She will be sharing her research related to the metabolically healthy obese. First, I'm going to start with a few housekeeping items. If you have any trouble hearing or seeing the webinar, please hang up and join again. It's most likely a problem with your internet connection. Our presenter is going to talk for about 30 to 35 minutes, and then we're going to have time for question and answer. If you have any questions throughout the presentation, we encourage you to type your questions into the question area on the GoToWebinar platform. If you purchased a CEC for today's webinar, you need to watch the entire webinar to receive your CEC. The CEC will be applied to your ACSM account within 2 weeks. When the CEC is accessible, an email will be sent to verified viewers. All right, now I would like to introduce Sarah. Sarah Kamhai, PhD, is an associate professor at the University of San Francisco. Her bachelor's degree is in kinesiology from the University of Michigan. She has a master's in exercise management / clinical exercise physiology from the University of Queensland, and her PhD in kinesiology is from the University of Maryland, where she has a specialization in physical activity epidemiology. Her educational and research training as a clinical exercise physiologist and physical activity epidemiologist has given her a unique perspective on examining the associations between lifestyle behaviors, obesity, and cardiometabolic risk. More specifically, her research has examined the role of physical activity, sedentary behavior, and/or diet in modifying cardiometabolic risk with obese individuals across the lifespan. At this point, we're going to welcome Sarah, and Sarah, we will turn it over to you for your presentation.
Well, thank you very much for that introduction. It's my pleasure to present to you today my talk, which I have titled Metabolically Healthy Obesity. Can we really be obese and healthy? Hold on one second. Okay, hopefully my slides progressed. So when I start off here, I want to have you think about what does it mean to you to be healthy? So I'm going to offer 3 definitions to get started. The first is health is the absence of any disease or impairment. The second is health is a state that allows the individual to adequately cope with all demands of daily life. And the third is health is a state of balance, an equilibrium that an individual has established within himself and between himself and his social and physical environment. So just give some thought to these definitions, and I want to point out that there are some limitations to these definitions. The first is that health to me is not a state, it's dynamic. So one day you might be healthy, the next day you might not be. The second is that health is very difficult to measure and quantify. How do you actually measure health in somebody is a really complex question to answer. And finally, there are many dimensions of health: physical health, emotional health, social and mental health. And so defining what it means to be healthy is actually quite complex. So if I show you this continuum of somebody who's unhealthy on one side and healthy on the other, where do we define being healthy? Do we have to get to this point to say that somebody's healthy? Or are we somewhere in the middle? So this brings me to the objectives that I am going to cover here today. The first is to explore definitions of metabolically healthy obesity and understand its relationship to health. The second is to explore body composition differences between those who are metabolically healthy and unhealthy obese. And the third is to compare lifestyle behaviors between these 2 phenotypes. So let's get started with objective 1, which is to explore the definitions of metabolically healthy obesity. So let's start off at the very, very basic level. What is obesity? The very simple definition is excess adipose tissue. How can we determine if someone is obese? There are many different tools, but a tool that I'm going to talk about is body mass index, which is the proportion of weight to height calculated as kilograms per meter squared. The World Health Organization has adopted this weight classification chart where 30 identifies somebody who is obese. And I'll draw your attention to this research by Gray at the bottom. It shows mortality ratio, or your risk of death, and it shows that as you go from overweight to obesity, class 1, 2, and 3, you can see a steep incline in your risk of death. So BMI is related to health. So a lot of people aren't familiar with where BMI actually comes from. So I thought I'd give you the 1-minute history lesson. So way back in the 1800s, MetLife Insurance realized that it was more expensive to give life insurance policies to somebody who was heavier. They had increased risk for chronic disease, and that increased their medical costs because they needed medications, they had more hospitalizations. So they wanted a way to easily identify individuals so that they could basically prorate or deny them life insurance. So Quetelet was a mathematician at the time, back in the 1800s, and he created Quetelet's index, which was an algorithm developed to easily identify someone according to their weight. So this is basically, Quetelet's index became our modern day BMI. And this is definitely a controversial tool, so I think it's important to show both sides because BMI is a very foundational tool in my research. Let's start with the positives. BMI is very fast and easy to assess. You just need somebody's height and weight. In some cases, people can self-report this to a very good degree of accuracy, or you just need a scale and a stadiometer. Number 3, it's really great for identifying patterns in populations. And we've been using BMI to follow the obesity epidemic in adults and children in the US. So for example, here we have the US adult obesity prevalence. Using BMI, we've been following people since 1960. You can see there was a steep increase in obesity in the 1980s. And our current prevalence estimates of obesity using BMI is 42% in adults. We expect this to rise, and by 2030, we are expecting about 1 in 2 adults will have obesity. I just wanted to show you we have the same pattern in youth. So about 1980, there was a steep increase in obesity, and our current estimates using BMI are about 19%. So it's not a perfect measure. There's always limitations. I started off this presentation by saying obesity was excess adipose tissue, and BMI does not take into account body composition or fat tissue for that matter. Here we have 2 gentlemen, exactly the same height, exactly the same weight. Their calculated BMI is identical. The person on the left has a lot of muscle mass, and the person on the right has a lot of adipose tissue. And so for certain individuals, especially those with muscle mass in large quantities, BMI is not necessarily a good tool to use. But I want to make the argument that BMI is related to percent body fat. So here I have a chart, body mass index here, plotted against body fat. And you can see in both men and women, as you increase body mass index, you also increase body fat percent. So there is an association, but it is a complex relationship, and I don't discount that. So I'm going to switch gears and talk about obesity and health next. So obese are more likely to have multiple abnormal cardiovascular and metabolic risk factors that co-occur. We call this clustering. So it is an obese individual that has multiple abnormal risk factors happening at the same time. So when you compare a person to normal weight, an obese man is 25 times more likely to have this clustering, and obese women are 14 times more likely to have this clustering. So obesity is super complex, and obese individuals, as I just mentioned, are more likely to have clustering. But clustering is not in all obese individuals. So I'm going to share with you some research by Corellis, who established obesity phenotypes, which is basically a fancy word to say different kinds of obesity. So he identified an obese individual who has high fat mass and an unhealthy metabolic profile. I'm going to call this, from here on out in this presentation, metabolically unhealthy obesity, or MUO. On the other side of the spectrum, we have another obese person, still high BMI, still high fat mass, but this time they have a healthy profile. we're going to term this person metabolically healthy obesity, or MHO. So really simply put, a person who's metabolically healthy and obese is an individual who has a healthy cardiometabolic risk factor profile. So I go back to ask you, how do you define healthy in this case? So I'm going to offer you a few steps that researchers go through in order to try and tease this out, healthy versus unhealthy. So the first question that we can ask is, which cardiometabolic risk factor should we evaluate? I've put a list of 9 up here. You can see there's some cardiovascular risk factors, there's some metabolic risk factors, there's also some novel risk factors in this list. The second question that I might ask is, how many cardiometabolic risk factors should be evaluated? At the very least 3, because we're looking at clustering. And so if we decide to include all 9 that I have on the list previously, and just for a frame of reference, you might be familiar with metabolic syndrome, which looks at 5 different risk factors. The next decision we have to make is, what threshold should we use to identify unhealthy? So for example, if I decide I want to include blood pressure, I have to decide what threshold would be unhealthy. So I've given some examples of maybe how we might define that. So I'm not done yet. Those are 3 decisions. And then the final decision is, how many abnormal risk factors can be used to define a healthy obese individual? So again, that MHO profile. So I have 3 options here. The first option is super strict, 0 abnormal cardiometabolic risk factors. Then we have one that's a little bit more lenient here at the bottom, option 3, which is 0, 1, or 2 risk factors that are abnormal. And just for frame of reference, again, metabolic syndrome is 3 or more risk factors. So basically this option is the absence of metabolic syndrome. I've starred this definition in the middle because it's my personal favorite, because it's somewhere in the middle, not too strict, not too lenient. And this is the one that I often use. But what I want to make the point is that there's 4 decisions that have to be made to identify somebody's health. And the literature does not agree and actually uses all these different combinations. So which definition is best? Well, we don't really know. And there's many combinations that exist in the published literature. There are different risk factors considered, the different number of risk factors, different thresholds for each risk factor, and different definitions for what constitutes a healthy obese individual. So that makes it very difficult to compare results across published research. It's like comparing apples to oranges. You really are looking at different groups of people if you don't have the same definition. So one of the first questions I asked when I was engaging with this literature is, what happens if you use different definitions to identify these individuals? So I borrowed some data from the Bogalusa Heart Study, and I identified people who are obese, and I split them up into healthy and unhealthy. You can see here that using a cardiometabolic clustering definition, the prevalence was about 60%. And I used another definition, an insulin resistance definition, and you can see the prevalence dropped to 46%. So what happens is, you use different definitions, you get different results. Likely, these are identifying 2 different groups of people and not the same group of people. So my future recommendations in this literature are to standardize the definition of metabolically healthy obese. I think it's important to make it clinically relevant. So that means use factors that are readily and routinely available and measured in your doctor's office, and use thresholds that are simple to use and interpret. So if we know that hypertension is 130/80, we should use that as the threshold. So you might be wondering, how common is metabolically healthy obesity, and who is this person? So I went to some literature by Wildman, who looked at this phenomenon in the National Health and Nutrition Examination Survey. For those of you who may not be familiar, NHANES is a data that's collected every couple years in thousands of individuals all over the United States. And this is how we establish our obesity prevalence in the United States. So of obese adults, men are about 29% healthy. Women are about 35% healthy. So it's about 1/3 of obese individuals. So this isn't rare. This is a sizable amount of people who are obese. I was really interested in children and adolescents. So I took the exact same data set, which is publicly available to analyze, And I looked at obese adolescents, and you can see the prevalence jumped twice as high. Almost 2/3 of obese adolescents are considered metabolically healthy. So through this research, we were able to note that you're more likely to be metabolically healthy if you're female, African American, younger, and have a lower BMI within obesity. So I want to explore the younger characteristic for a moment. So what I've done here is I've plotted the data that I took for adolescents and the data that Wildman had for prevalence by age group. And what appears to be happening is that as we age, there is a decrease in metabolically healthy obesity. But I want to point out this is cross-sectional data, so we're not following a person over time. These are just snapshots in time of people at certain age groups. So at the time, there weren't a lot of longitudinal studies to follow a person over time. One of the comments I made at the beginning is that health is a dynamic state. So my next question was, is metabolically healthy obese a dynamic or a stable condition? So I updated the obesity phenotype labels, and the first label that I gave was someone who was stable and MHO, which was an obese person who remains healthy over time. So I measure them at a point in time, they don't have any clustering, and then over time they remain that way. The second phenotype that I wanted to see if it existed was something called transient MHO, which is a person who has no clustering at a particular point in time, and then over time they develop the unhealthy profile, so they transition. The third phenotype was someone who was obese and unhealthy at one time point, and then over time they remain that way. So I thought it might be interesting to follow people over time and see if their phenotypes changed. So I was lucky to use the Cardia dataset, which followed people over 30 years. And you can see at baseline, it was back in the 1980s. You might remember I mentioned that is when the obesity epidemic started. And so the adults in this study were young adults, and they followed them over 30 years in this particular data until they were middle-aged. So what I did is I took anyone who was not obese at the beginning, and I followed them over time and figured out when did they become obese. So in this particular example, this individual became obese at year 7. And so I'm calling that development of obesity. When did they develop their obese state? And then I followed them over time and I determined how long were they obese for over those 30 years. The third thing I did was discover what phenotype they had. So were they stable, were they transient, or were they unhealthy? So I established their phenotype when they became obese, and then I followed them over time to see if that changed. So here's what I found out. It's actually split almost in thirds. Those who were healthy the whole time over 30 years of their obesity were 35%. Those who transitioned were about 32%. Those who were unhealthy the whole time that they were obese were about 33%. Something else interesting that I found in this research is the duration or how long somebody was obese. And you can see here that the person in the middle here, transient, a person who started off healthy and transitioned over time to being unhealthy, had longer duration of obesity by about 5 years. So this research made me realize a few things that were really important to my research moving forward. Number one, obesity phenotype stability varies. It's important to know when a person becomes obese. It also matters how long you have been obese. And the longer you are obese, the more likely you are to become unhealthy. So very clearly, these states of health are dynamic. So I want to go back to the characteristics that are likely to make a person metabolically healthy and obese, and I want to revisit lower BMI within obesity. This whole time we've been using BMI to mark and measure obesity, and so that leads us to the second objective, which is to explore body composition differences between metabolically healthy and unhealthy. So adipose tissue is super important to measure, and so my question was there a difference between the two phenotypes in quantity or quality? So I was able to use the Pennington Center longitudinal study. Here we have DEXA, which is our gold standard of measuring body composition and percent fat. In the dark green are metabolically healthy individuals, in the light green are unhealthy. you can see there's a significant difference where metabolically healthy individuals have less fat mass, whether you measure in percent or total fat mass. Next, I wanted to look at quality of adipose tissue. So the way that I look at quality is where it is located. So way back in the 1940s, there was a doctor who published, looking at his patients, he realized that where they stored their fat mattered. He identified an android or apple-shaped obesity where somebody accumulates fat in the abdominal cavity and internal organs. We're going to call this visceral fat. It was more common in men, and it was associated with chronic disease. On the flip side, there was another type of obesity called gynoid or pear-shaped. This is where fat accumulates in your hips and your thighs and under your skin. I'm going to call this subcutaneous fat, and this was more common in women and not associated with chronic disease. So adipose tissue location matters. It relates to disease. So is there a difference between the obesity phenotypes and where fat is located? So this brings me to sumo wrestlers. Sumo wrestlers are elite athletes. They have very high BMIs. They have lots of adipose tissue. But what's really interesting about these athletes is they also have the metabolically healthy obese phenotype. So there was some research done by Matsukawa in Japan, and he looked at the location of adipose tissue in sumo wrestlers. Just to orient you to this picture, on the left, we have the average obese adult. The black outline here is subcutaneous adipose tissue. Oh, I should say, this is a computer tomography scan. So if you split yourself at your belly button and opened yourself up, here's your belly button. These dark images are your internal organs. So this black outline is subcutaneous fat. The white highlight region is your visceral fat, and you can see the average obese adult has very high levels of both. Here's the sumo wrestler. You'll see there's still a lot of subcutaneous adipose tissue here in the black, and also in the black, this is the volume of visceral adipose tissue in a sumo wrestler. If you compare the black here to the white here, you can see there's a lot less volume of visceral adipose tissue in the sumo wrestler. So I thought, well, if sumo wrestlers have this, what about normal people who are not elite athletes and wrestlers? So I used the Pennington Center longitudinal study, I used computer tomography scans, and we looked at visceral adipose tissue and subcutaneous adipose tissue, and we found that metabolically healthy in the dark green hair here had significantly less visceral and subcutaneous fat. So is having less adipose tissue healthier even if you are obese? So I have a picture here of percent body fat, and there are a slew of chronic diseases listed here: hypertension, diabetes, dyslipidemia. And if you're metabolically healthy and the obese side of the spectrum here, you're at higher levels of percent body fat. If metabolically healthy is a little bit further down the spectrum here, does this result in a difference in chronic disease? Are you healthier if you have less body fat but are still obese? That was my next question. So I went to the literature, and I'll tell you that the results were all over the place. So for every study that I found where metabolically healthy obese was better, I found studies that showed no difference between the two phenotypes of healthy and unhealthy. So I was a little confused because I thought, well, the literature is telling me a very confusing story, until I sort of realized why. Why didn't the results agree? Number one, they were using different definitions to identify those who were healthy. Number two, they were examining different chronic diseases, sometimes cardiovascular disease, sometimes diabetes. Sometimes they were analyzing whether someone had disease or whether they were dying from the disease. And number four, the studies didn't examine the obesity phenotype stability, whether it was dynamic. They didn't take into account when somebody became obese or how long they were obese, which was something I found in my research to be really important. So I thought, well, I can do that. So I borrowed some data from Cardia, and I decided to look at coronary artery calcium, also known as CAC. CAC is basically a measure of your coronary arteries, looking inside and looking to see how thick the plaque cholesterol buildup is inside. So I took a group, again, of non-obese individuals. I calculated when they became obese and also whether they had coronary artery calcium in their arteries and whether this changed over time. So let me present the results to you here. Let me orient you to this graph. So here we have non-obese individuals. So a person who never became obese over the 30 years. And then we have all of our obese phenotypes on the bottom. Stable, metabolically healthy obesity, and those who never became obese had no difference in their coronary artery calcium. Those who transitioned at some point during their obesity were 2 times more likely to have a change in coronary artery calcium. What does this mean? It means they had development and progression of cardiovascular disease, and they were 2 times more likely to do that compared to somebody who was healthy the whole time. Not surprisingly, those who were metabolically unhealthy were at the highest risk for having coronary artery calcium. So far, compared to those who are unhealthy, metabolically healthy have less fat, less visceral and subcutaneous fat, and less chronic disease development and progression. So my next question was, well, how can we move somebody from unhealthy to healthy? Is it possible to do this? And this leads me to my third objective, which is to compare lifestyle factors between healthy and unhealthy obese individuals. So let's get started. I'm going to go back to those sumo wrestlers. They are elite athletes, and athletes always have in season and out of season. They train a little bit harder at certain times. And what Matsukawa found is when they stopped their physical training, they actually transitioned to unhealthy. So that made me really question, well, what is the role of physical activity? So I'm going to introduce you to this physical activity model of the 24-hour activity cycle. And I'm a physical activity epidemiologist. I'm always interested in how physical activity affects your health. So I started off here at the bottom looking at moderate to vigorous and light physical activity. And I wondered, what is the role of physical activity? So a little brief background on what was available at the time. No surprise, there were conflicting results. Some studies suggested that those that were metabolically healthy had greater amounts of physical activity. Other studies said no difference. But at the time, most of the data available was questionnaire data. And there wasn't a whole lot of information on other intensities besides moderate to vigorous or other forms of physical activity, such as strength training or flexibility. So I thought, well, I can do something about that. And so I measured a group of obese adults. I strapped them up with an actigraphic accelerometer, which is an objective measure of physical activity. And I measured them in a study that I called Project Health. So just to orient you here, metabolically healthy obese are here on the left, metabolically unhealthy are here on the right. I'm going to start off by showing you that moderate to vigorous physical activity was not significantly different between the two groups. However, light physical activity was greater in those who were metabolically healthy. Almost 40 minutes difference per day, greater light activity in those who were healthy. There was also greater METs per minute in those who were healthy. So METs per minute basically means how much movement you're getting throughout the day. So metabolically healthy obese were moving more. So if I look at this 24-hour cycle, I was able to establish equal amounts of vigorous, moderate to vigorous physical activity when comparing the phenotypes, more light physical activity. So my next question was, how much sedentary behavior is in these individuals, and does that differentiate these phenotypes? So brief background on what was available at the time. Very limited research. Most of it was questionnaires asking people, how much time do you watch TV, which is a proxy measure for sedentary behavior, and really no objective assessment of how much somebody was sitting. And so again, using my Project Health data and using the actigraphic accelerometer, we were able to show that metabolically healthy obese individuals had almost an hour less sitting time compared to those who were unhealthy. So less sedentary behavior and more light physical activity. And so the summary so far, those who are metabolically healthy obese should move more and sit less. The next piece of the pie, the remaining piece of the pie here is sleep. And so while I haven't looked at this myself, there have been some studies that have come out more recently that have looked at sleep in these obesity phenotypes. And I'll say the jury's still out. So there are a couple studies that look at quantity of sleep, some that look at quality of sleep, and the results, some say it's better in those who are metabolically healthy, some say there's no difference. I think this is something that we need to look at a little bit more carefully, and hopefully over time we might be able to answer this question a little bit more carefully. So I just presented to you sedentary behavior and physical activity, which to me is part of the energy balance equation. And so we just kind of summarize by saying we should be moving more and sitting less to get people healthier in obesity. But let's look now at dietary intake. What is the possible role of diet in this equation? So very brief background on what existed at the time that I was interested in looking at this. No surprise, there were conflicting results. Some studies showed there were differences between the phenotypes, others showed no differences at all. At the time, there was really specific groups that were studied. And as I mentioned previously, metabolically healthy obese individuals are more likely to be African American, younger, and women. And I didn't feel like the literature at the time really represented the people that it was most likely to be in. So going back to my Project Health study, I used the Block Food Frequency Questionnaire, and I quantified diet quantity, macros and micros. So you can see here calories, carbohydrates, fat, protein, sodium, and calcium. And there were no significant differences in any of these variables between the two groups. But when I think about food, I think that we eat foods that are combinations of macros and micros. So what I mean by that is when we eat an apple, it is not just carbohydrates. It also has a combination of fat and protein. And so foods are mixed. And so I thought it was important that we look at foods. And so I was also able to look at diet quality and look at summary data variables that look more at foods and food groups. So what we were able to show is that those who are metabolically healthy eat more vegetables, less dairy, and more fiber from beans and fruits and vegetables. So clearly there was a difference in quality of the diet. I was also able to look at this using the NHANES data, and there is a way that you can score somebody's diet using an index called Healthy Eating Index. And basically it refers to how well you meet the guidelines for what we recommend as a healthy diet. So the higher your score, the better you adhere to the guidelines. You can see here metabolically healthy in the dark green, whether you're an adolescent or you're a young adult, are more likely to have a better quality or higher score than those who were unhealthy. So if we look back at energy balance, basically quality matters, not quantity. So that's my summary of the energy balance and what we see in those who are metabolically healthy. So I'm going to finish up by just talking for a moment about obesity and weight loss. Weight loss is the primary focus for treating obesity, but weight loss is very difficult to achieve and maintain. And I have this quote from an article from Phildis that said, for patients with a BMI of 30 or greater, maintaining weight loss was rare and the probability of achieving normal weight was extremely low. Research to develop new and more effective approaches to obesity management is urgently required. So I ask you this, can we improve health within obesity without weight loss? Can you be healthy and obese? Should the goal be to move somebody towards healthier within obesity? So if you are obese and unhealthy with clustering of risk factors, can we move you to not have clustering, to be healthier within obesity? So what are some possible intervention strategies in order to accomplish this? Well, my research so far has suggested maybe moving more, not worrying about intensity, sitting less, and improving the quality of the diet without worrying so much about the quantity of what is in the diet. So I ask you this, can we improve health and obesity without weight loss? So I'm going to go back to the very, very beginning and ask you, what does it mean to be healthy? And if we think unhealthy is somebody who has an unhealthy profile and is obese, is healthy somebody who's normal weight? If we can move somebody from unhealthy obese to healthy obese, is that considered healthier? Is that better? So in conclusion, can we be obese and healthy? The research that I've showed today has proven that metabolically healthy obese have less fat in their viscera and subcutaneous regions, less chronic disease progression, more light activity, less sedentary behavior, better quality diet. So in my opinion, metabolically healthy is likely a healthier state compared to their unhealthy counterparts. But really, it's probably an intermediate risk between those who are normal weight and those who are unhealthy and obese. So there's a little caveat to my presentation, and that is, hopefully you've caught this along the way. It really depends on how you define MHO, how long somebody has been obese for, and the stability of that phenotype. And while we've been able to explore this a lot in my first 3 conclusions, the lifestyle factors really needs more research. We haven't been able to take into account all of these nuances of what it means to be healthy and obese yet. So I'm going to conclude by thanking my mentors and collaborators. There are many people involved in this research at many different institutions around the US, many students and technicians who I owe a very large debt of gratitude. I was supported by several funding mechanisms which helped me to accomplish this research. And so I finish up today, and thank you for your attention and for attending today, and I welcome any questions or comments.
Great, thank you, Sarah. That was awesome. At this point, we'll have you turn on your video so that we can put a face with the name, and hopefully people will look for you next time they're at an ACSM conference. So just a reminder to everyone, go ahead and type your questions into the question area on the GoToWebinar platform, and we're going to get started. So Sarah, do you know what the prevalence of MUO and MHO among the population with obesity in the US? Do you know what those prevalence rates are right now?
Yeah, so they're about the same as what they were when we looked at them previously. So it's about a third of obese individuals are considered metabolically healthy in adults, and then in children it's about 2/3. I should say children and adolescents, it's about 2/3 healthy.
Okay, great, thank you. Do you have any thoughts about making, so when you were talking about the different definitions, do you have any thoughts on making those definitions, specific by age and gender?
I think that could definitely be possible. So I think standardizing the definition, as I mentioned in my presentation, is really important. And understanding that different thresholds are needed at different ages. So for example, a child has a different threshold for identifying hypertension compared to an adult. So I do think that you should have age-specific definitions that are relevant for the risk factors where that is needed. So absolutely.
Great. Have you been able to look at the role of genetics in all of this yet, or are there any existing data sets where you can look at the role of genetics in some of this?
Yeah, that's a great question. I personally have not looked at genetics. I think that there are a couple papers that have looked at genetics of metabolically healthy obesity, and there is some suggestion that we know that, for example, having abnormal lipids is a genetic predisposition. So it makes sense that those who are obese and healthy is also possibly genetic. Also, it's more likely that if you're an obese adult, your children are more likely to be obese. So there's definitely a genetic factor here. And while I haven't studied it, there are some published papers out there that do explore this a little bit more. And it is a really great question because some of this may be able to be explained by genetics, but I still want to hold on to the fact that we can modify some of this through lifestyle. So while there is a genetic component, there's also a non-genetic component that involves behavior.
Awesome. All right, our next question is, do you find any characteristics with women peri and postmenopausal?
So I haven't looked at the at menopausal status specifically, like that transition from peri to post. That's a really interesting question because we know that when women are going through menopause, they are more likely to get abnormal risk factors. And so that would be a really interesting study. I encourage whoever asked that question to look at that. Because as we transition through menopause, women are more likely to have increased risk for cardiovascular disease. So that would be a really interesting time to look at the stability of this phenotype and maybe when people switch or transition. So I encourage whoever asked that to look at that. That's a really interesting question.
All right, here's another question for you, Sarah. Why do you think African Americans and females were more likely to be metabolically healthy when they are also tend to have lower physical activity rates?
Yeah, that's a great question. I wish I had the answer, but I don't. You know, it's a really complex question to answer. I think the concepts of race and ethnicity are really hard to describe. Some of it can be cultural, some of it can be genetic. And I think all of this kind of mixes up to make it hard to tease out exactly why, what the causes are, or what makes somebody more likely to be something. And I think this is a great question that I can't necessarily answer with the research that I've done. But I think that it just begs the question, you know, someone needs to find out why and explore those reasons. But unfortunately, we're not able to answer that now with what we have available.
Awesome. So this question is specific, but I think it brings up the point about mental health and stress. So this person has mentioned that they've noticed that obese clients that they have that are coming from places like India where they practice yoga or meditation, they often don't have the typical complications that US folks have. So have you looked at anything related to stress or mental health or other cultural factors even?
Yeah, I think that's a great question because it gets at the concept of health, like how are we defining health? And mental health has a really big connection to physical health. And what I presented was mostly physical health. And I am not familiar with whether there's anything out there. We know that people who practice mindfulness and stress reduction techniques there are physical, how do I explain this? There are physical benefits to that. And so I have not been able to necessarily look at practicing yoga or other forms of mindfulness activities and how that relates to stress. But if I were to take a guess, I would say that those who engage in those practices would be and have lower levels of stress would be maybe those who are healthier. So I think that's a really great question. And again, I encourage whoever asked that to make that part of their next research project.
All right, this is an interesting question that came as well. Have there been any attempts to standardize the MHO definition using tools such as machine learning or AI?
That's a great question. Not to my knowledge, but you know, the problem is that because so many definitions exist, I think someone wrote a paper and said there are like 30 different definitions. It's a huge problem in really establishing what is going on in the field. I think that is a great kind of way to think about how to find the best definition. But I think, you know, besides sort of AI and machine learning, really making sure that whatever is decided that it's accessible and relevant. So not including risk factors that maybe are not routinely measured and making sure that whatever is decided for the standardized definition, that it makes sense clinically so that it's something we can easily assess and measure in people to establish their phenotype. So I think that's a great approach to thinking about taking all the definitions and trying to figure it out. But how do you determine what is best? I don't know. Do you look at, you know, the disease rates over time and figure out who really is healthy? I think it's a really difficult question to answer. How do we know what's best? So maybe AI is the way to go.
All right. So This person is asking, have there been any comparison studies between MHO versus people with normal BMI? So most interesting, the sedentary, unhealthy, skinny, in air quotes, phenotype.
Yeah, so normal weight unhealthy is another phenotype. A lot of the research studies that I looked at actually split up all of the obese, or I should say all of the weight status categories into unhealthy and healthy. So they look at normal weight, unhealthy and healthy, overweight, unhealthy and healthy, and obese, healthy and unhealthy. So a lot of the papers that I mentioned today actually look at 6 phenotypes. So a lot of research suggests that people who are normal weight and unhealthy are actually some of the most, how do I say this, most unhealthy individuals. So being skinny and unhealthy is actually very bad for your health because you're more likely to develop cardiovascular disease and diabetes. So while I focus just on the obese categories today, a lot of research actually splits up the weight status categories into all, and they're comparing all of those together. So definitely look at some of the literature. You'll see that there's a lot of papers on normal weight, unhealthy individuals as well.
Great. So we have time for just a couple more questions. This one says, this is a little bit more applied. How do you envision using MHO in combination with BMI when working with adults trying to lose weight and improve lifestyle?
Yeah, that's a great question. So you can basically focus on their cardiometabolic risk factor profile. And if they can reduce their risk factors, you're moving them towards being healthy. So somebody who is identified as having a BMI in the obese category and they're incorporating some lifestyle changes, or maybe they're working with their doctor and having medications, the idea is to not worry so much about the weight loss, but worry about the cardiometabolic risk factors, and constantly be checking to see if they're improving or changing. Now that's easier said than done. Again, we need the research to show that that is possible, and that doesn't exist quite yet. But I think BMI is, again, one tool that we can use to quickly assess whether somebody is obese. And then their cardiometabolic profile is really what I'm saying is the focus. So if you're working with someone who's obese, don't worry so much about their weight status and worry more so about their cardiometabolic risk factor profile, and see if you can move risk factors in a positive direction towards healthier, if that makes sense.
Yeah, and this is an interesting question too. It says, what is the overall relevance, of measuring obesity? Can we get rid of it and just stick with the metabolic factors?
Yeah, I think that's a great question. I think obesity on its own, even not looking at kind of the cardiometabolic risk, is still an important risk factor. Body composition is a measure of health. It's very well established in the literature. And so I don't think we should get rid of it, because I think it gives us a lot of information. And what I'm trying to tease out is that there's different types of obesity. So if we, being obese is an important thing to measure. And while we don't have the ability to measure everyone's adipose tissue, which would be ideal, it's not practical. And so, that's kind of where BMI comes from. But I still think obesity is an important health metric in order to identify, a person's risk. But it's not the only measure. And so the idea is it's one of many things that we can do to measure health. I sort of said at the beginning, how do you quantify someone's health? Well, obesity and obesity status is one way, but it's not the only way. So again, there's lots of ways to describe health, and obesity is still an important metric, in my opinion, to use.
All right. So our final question, this is back to more of the psychology related to all of this. The question is, to what extent do you think physiological effects of weight stigma, for example, increased cortisol, might play a role in these patterns? Are participant experiences of weight stigma assessed or controlled in any of these studies?
That's a great question. I know that there's been a lot of research lately on the stresses of being obese for mental health, and there's some research to show that kind of weight bias and weight stigma and that social context does have some negative impact on mental health. And that can have a negative impact on physical health, as mentioned with cortisol levels. In my knowledge, in this research, there hasn't been anything that quantified weight stigma or stress, as I mentioned with another question. I think this is definitely something that needs to be taken into account and is a big gap in the literature, and a great way to kind of progress this forward, looking at the social context of obesity and what that role might play in metabolically healthy and unhealthy obesity. So I think that's a great place for future studies to explore.
Okay, well, thank you so much, Sarah. This was a great presentation. Full transparency, there were a couple of us here eating snacks during your talk, and now we feel very guilty because it wasn't, they weren't high quality snacks.
Remember, it's quality, not quantity. So just balance it out through the rest of your day.
Feel bad. We're gonna eat well the rest of the day. So a final reminder for everyone else, if you purchased a CEC for today's webinar, that will be applied to your ACSM account within 2 weeks. When it's ready, we'll send you an email so that you have some instructions on how to access your CEC documentation. Also, everybody who's registered for the webinar today will be sent a recording of the video. Several of you were asking if they would get a copy or a copy of the slides. We will send a video. That usually takes about a week. We will get that out to all of you. We want to encourage all of you, if you're not ACSM members, visit the acsm.org site and look into our membership. And a reminder that our annual meeting is in San Diego this year at the end of May, and we would love to see you all there. So with that, we'll say thank you again to Sarah and to all of you for your participation today, and have a good rest of your day.